Module 3, Complex and Emergent Respiratory Disorders. Okay, we're going to start with different oxygen delivery devices. So non-invasive positive pressure ventilation. So non-invasive means we're not sticking anything inside the patient. So NPPV, or non-invasive positive pressure ventilation, delivers positive pressure to the airway without the use of an artificial airway to keep that alveoli open. And it also decreases the risk of nosocomial infections. So nosocomial infections means infections that the patient did not come into the hospital with, but got it during their hospital stay. So we don't want those. We don't want to give the patient anything that they didn't come in with. So NPPV, we're talking about the CPAP and the BiPAP. So CPAP is continuous positive airway pressure. So for patients who have like sleep apnea, they usually will go home with a CPAP. So this has a preset continuous positive pressure throughout the respiratory cycle. So a respiratory cycle means you breathe in, you breathe out. There's a continuous pressure, and this is going to help to keep that alveoli open, to keep that airway open. So the BiPAP is a bi-level positive airway pressure. So there's two different pressures, and they're both preset, so you're not changing these. That is delivered through an inspiration, and the other is during exhalation. And BiPAP will be that last type of oxygen delivery device before intubation if the patient continues to decline. So then we have our artificial airways, such as the endotracheal tube or ET tube. So this can be inserted through the mouth orally or through the nose. And we call this intubation. You don't have to be a physician to do this. You can be an NP, you can be a PA, you can be a respiratory therapist with special training. So who manages this? Both the RN and the respiratory therapist can manage this. So your role as the RN is to make sure that that you take care of the patient during intubation, and then after the patient is intubated, of course, we're going to talk about your responsibilities. So nursing considerations. We are going to use the ambu bag to deliver 100% of O2 during the intubation procedure. So this is when they're setting up their equipment, the patient is not breathing well, which is the whole reason why you have to put an ET tube in. You're going to make sure you give them as much oxygen as you can in the meantime. You're also going to continually monitor their vital signs, their oxygen saturation, and any signs of hypoxia like dysrhythmias. And you don't want them to aspirate, because the whole purpose they're needing this is because we need to protect their airway. So during this process, we want to make sure they don't get any worse. Once they insert that ET tube, then we want to make sure placement is verified by either using an end-tidal CO2 device. That is something that sits right below the nostrils that is going to measure how much carbon dioxide is exhaled. We want to make sure we see symmetrical rise and fall of the chest, because if it's asymmetrical, that means that tube is probably in too far into one of those big bronchial airways. So it needs to be right above the carina, which is right before they branch out, so that the air gets distributed evenly. Equal bilateral lung sounds, and no sounds, of course, heard over the abdomen, because that means that they put it into the esophagus. And of course, definitive confirmation would be that chest x-ray. So why does a patient even need an ET tube? So maybe they have an upper airway obstruction, episodes of apnea, high risk for aspiration, ineffective airway clearance, and some other type of respiratory distress. Okay, so assisting with intubation, here's our light bulb. So you as the RN need to make sure that whoever is inserting this ET tube does not take longer than 30 seconds. So if you're looking at the clock and they're like, that tube they've been trying to do that for 30 seconds, they need to stop and take a break so that you can continue to bag the patient with oxygen, because during that time, the patient is probably desatting, and they could end up going into respiratory arrest, cardiac arrest. So we don't want that. We need no longer than 30 seconds. You also want to gather an intubation tray and the CO2 detector, so you can gather supplies for the bedside for the provider. You may want to have restraints available. That does not mean you have to use them. It's not an automatic for every intubation the patient's going to be on restraints. Remember that. You want to have them available, but it doesn't mean that every patient is going to get them. And then you want to ensure suction is available just in case. And then once the procedure is done, you are going to document your full assessment of the patient, the ET tube size, the position, the location, using centimeters. And you want to also document the ventilator settings and the patient's response to the procedure. Continued with your RN role when it comes to these ET tubes. Maintain a patent airway because the patient cannot clear the secretions on their own, so that means we need to suction out secretions. Monitor for complications, which we'll talk about. Maintain proper cuff inflation. This is primarily managed by the respiratory therapist. And usually respiratory therapy does not want the RNs messing with this, but you should know how to do it just in case. So this cuff that you can see here in this picture is a balloon. Okay, it looks like the end of a Foley catheter, but the purpose is different. So the purpose is to keep it in place, but also not to let any air go around the tube because we want it all to go through the ET tube. So we want to make sure there's proper cuff inflation. You want to check at least every 4 hours, and there should be 20 to 25 millimeters of mercury of air at any given moment. But if it is hyperinflated, like there's too much air, it can actually cause tissue damage to all that tissue in the airway, and we don't want to do that. We want to provide oral care. That means clean the mouth with chlorhexidine every 2 hours when a patient has an ET tube. We want to make sure we keep the mouth as clean as possible because we don't want that bacteria sliding down the throat into the lungs, and then they aspirate, and then you get like aspiration pneumonia. Suctioning, you assess the need every Q2 hours. You're assessing the need. You just don't do it automatically because every time you pass that catheter in, you could potentially injure the tissue on the way down. When you suction, you can be suctioning against the wall of the lung. We don't want to do that. You're going to assess breath sounds for adventitious lung sounds like wheezing, crackles, or rhonchi. Coughing, you could sometimes hear it with your ears. You don't even need the stethoscope. If the patient begins to have some respiratory changes like they're breathing faster or their heart rate increases, these are all indicators that they probably need suctioning. Decreased O2 level, if you see their saturation is going low, visible secretions, and they're restless. This is all like needing oxygen, so we want to make sure we identify that early. Maintain correct tube placement. Just like an NG tube, it can become, it moves, you reposition the patient, or maybe the patient even moved it themselves with their hand. So you just want to make sure it stays in whatever spot it was when it was first put in and placement was verified. It should stay in that place. Monitor oxygenation and vital signs, and educate the patient and family members on what to expect before intubation, what to expect after intubation. So complications of intubation include unplanned extubation. So the patient still needs the airway, still needs that ET tube, but it came out. So this can happen. Maybe the patient pulled it out and they actually need restraints, or maybe it was dislodged during repositioning or something like that. So that can happen. You just want to be aware of that. Aspiration, because we are bypassing the body's normal doors, our epiglottis, all of these structures in the larynx are meant to open and close as needed, but we're keeping it open with an ET tube. And infection, of course, because we're introducing a foreign tube into the body. We want to always maintain the head of the bed at least 30 degrees. Once you go lower, higher risk for aspiration, and it also makes it more difficult for the lungs to expand. Remember, as we sit up, that helps with lung expansion. Daily sedation, vacation, so turning down that sedation just to wake up the patient to make sure that they're still in there, right? And to see the appropriateness of the sedation. Maybe they could use less sedation. GI prophylaxis, because we're in the hospital, we get stressed out, we make more acid. That can lead to peptic ulcers. So they're going to be on some type of GI prophylaxis. Usually it's going to be IV push of some kind, like Protonics. And then DVT prophylaxis, because they're likely to have immobility or way less mobile than a person not in ICU. So we want those SCDs, those sequential compression devices on, maybe even compression stockings depending. Early ambulation, not every patient in ICU is non-ambulatory, so if they can walk, we do want them to walk. Invasive oxygen delivery continued. So what is the ABCDEF bundle? So this you will see in the hospital. Sometimes there's signs on the wall, especially in ICU. And this is something that's evidence-based. So you'll see this in multiple facilities. And it's an approach we use to care for critically ill patients at the bedside. It's designed to prevent oversedation, prolonged ventilation, delirium, and other stuff that happens when patients are in ICU. So we want to assess, prevent, and manage pain. Okay, pain is really big in ICU. It's always going to be one of our top priorities. spontaneous breathing trials and spontaneous awaking trials. This is where the sedation vacation comes in, and we want to see the appropriateness of the ventilator, because as soon as we intubate a patient, when we put them on a ventilator every day, every shift, we're trying to get them off. Like, what is the barrier? Is it because, you know, the lungs are still inflamed, they're still injured, they're not able to get off the vent? Like, what is the reason? We have to have a reason. If the reason that they're on the ventilator has gotten better, then we're going to try trials. Like, let's decrease the settings on the vent to see if the patient can do more of the breathing effort, more of the breathing work, to see if we can get it off. And that's something that you have to be knowledgeable when you get the report on your patient, because during rounds in ICU, they're going to ask you, so why is this patient still here? Can we downgrade them? Can we extubate? Like, what is the barrier? Choice of analgesia and sedation. Again, if you're looking to wean a patient off, then propofol will be transitioned to Precedex, because Precedex, as we talked about, does not depress the respiratory ventilation as much as propofol does. So that's where that comes from. Delirium. So there are lots of reasons why somebody may experience delirium in the ICU. So we want to hopefully prevent that from happening. And if they do experience it, we want to manage it. So you should definitely know the risk factors and what do we do to prevent it. Early exercise ambulation. Again, we want range of motion. If the patient isn't able to get out of bed, we want them to move their body. Whatever their baseline is, we want to get them to that point. Family engagement and empowerment. So having a support system is important. If a patient is conscious, they hear their family, they know they're there, it helps them to heal faster. This is evidence-based. Tracheostomy. So this is also an artificial airway, and this is indicated when we know they've been on the ventilator too long. So per your textbook, if the patient's been on there longer than 7 to 14 days, then there's going to be a conversation to consider putting a tracheostomy in place. Now, if the patient has reached the 14-day marker and they're actually improving, and there's a chance that in a couple more days of just practicing being off the ventilator, maybe they won't have to trach, then they're going to do that. So 7 to 14 days is not a hard stop. Like, okay, 14 days, we had to get you off. It just depends on the patient. So advantages to a tracheostomy: decreased airway resistance, decreased work of breathing, improved oral care, improved suctioning, improved patient comfort. Patients who have been intubated and they're alert and oriented, as soon as you transition to a trach, they feel so much better. So it can be scary for the patient who's never been around a person who's had a trach before, or just the thought of going into surgery and them cutting, close to in your airway. That can be very scary. But once they get through that and they come out, it is so much more comfortable for them, and you will see it in their face. It can be temporary, it can be permanent. Of course, if it's temporary, every day again with the trach, we're assessing, how can we get them off the trach? How can we start the weaning process? The type and size are going to depend on what's going on with the patient. If they just got off the ventilator, they're going to have a standard trach with a cuff, and you'll see what that means on the next slide. So there are lots of different tracheostomy tubes. If they're coming off the ventilator, they're going to have a cuffed trach, just like they had a cuffed ET tube, and that's going to keep it in place, and it's going to block the air just like the other one. But as they become stronger, and if they're able to wean, then we can remove the cuff, so we let air pass through more like a normal airway. Once you have air passing through that tube, you may hear a voice, because air needs to pass through the vocal cords in order to make sound. And when you have a cuffed trach, there's no air going through the vocal cords because it's all going through the tube. So if you deflate it, you could potentially hear a little voice. And of course, that has other determinants too, like if their vocal cords weren't damaged, or there's a lot of other things. But that's one step closer to hopefully weaning off the trach. Changing to a cuffless trach, or even a fenestrated trach, which has holes in it, like you can see here. Again, the whole idea is that you're letting more and more air pass through, which is more close to natural breathing. So once they put a trach in, right when they come back, they are considered a priority. Not only is it a post-op patient technically, but we're dealing with the airway. So we want to be really careful, because that stoma is immature. Once that stoma heals, it kind of becomes like an ear piercing. It's a stoma, but it can heal and it will stay open. But right at the beginning, if this thing comes out, like within the first day or two, that stoma is going to close really, really quickly. So we want to be careful with accidental decannulation. Same like ET tube, that thing can be pulled out. Pneumothorax. So pneumothorax happens when there is some type of injury that happened during placement. So maybe that ET tube punctured the trachea or punctured the lung somehow, or an instrument they were doing punctured a hole, so it's going to let air escape into that pleural space in the lung, right just outside of the lung. Subcutaneous emphysema, very similar. Somehow there was a puncture that let air through under the skin. So both of those things, especially the pneumothorax after a trach, usually results in some type of incident report because it was probably an error. Not 100% of the time, but most of the time. Infection, because there's now an incision, there's a foreign body in there. Tracheal stenosis, so as that trach heals, it can become really narrowed, and they may need to have another procedure to open up the trach before them being able to wean off the tracheostomy. And then a tracheoesophageal fistula, so this occurs when that trach, there's like a bridge between the esophagus and the trachea, which is really bad because one is sterile and one is not sterile, right? So our esophagus is not sterile, our trach is supposed to be sterile, so that can cause issues. And again, that can happen from an error during placement, or it can happen over time if there's like some wearing down of the mucosa, it makes a little tract, and then there you have a fistula. So best practice, as you see here, we should keep an extra trach set at the bedside along with a ET tube placement tray. So in my experience, I haven't seen ET tube trays at the bedside because they're usually in the crash cart, and you bring the, if something like this happened, the crash cart would be brought, and there are several ET tube trays inside the crash cart. But what you will see are the trach kits in the box at the bedside, and we like to keep it at least one size smaller, because we know with a fresh new stoma, it's going to close up right away, and we don't want to try to like force the same size if that thing has already started to close. So we usually keep the smaller size at the bedside. So now we're talking about the ventilator, mechanical ventilation. So this is going to be required when a patient can't breathe on their own, when they can't adequately ventilate, meaning they cannot breathe in that air, they cannot exhale that air. Indications: respiratory failure, heart failure, exacerbation sometimes of COPD, if they go into cardiac arrest and we need to protect that airway, drug overdose, respiratory depression, spinal cord injury. So if you have those really high cervical spine injuries, then they're not going to be able to breathe on their own. And the goal is to support the patient until that other, whatever the reason, is corrected, and hopefully get them off the ventilator back to their baseline if possible. So next is mechanical ventilation, and there are two main types. The first one is negative pressure ventilation. You're not going to see this that often. So this is related to like neuromuscular disorders that impede normal respiratory muscle function. So this is all about muscles. So if you have a patient with polio, for example, there was one in the news, I think it was the oldest person living in an iron lung who had polio. So this has to do with the muscles that are required to breathe. So the first picture here is the chest cuirass ventilator. So it's on the outside, and it provides like forceful negative pressure against the lungs. And then this one is a modern iron lung, the one on the bottom, and it's essentially doing the same thing. So these are non-invasive, so they're actually on the outside of the body. Nothing is going inside the body. And again, you're not going to see this very often. What you are going to see is the positive pressure ventilation. So when you ventilate someone, they're going to need an ET tube or a tracheostomy. So this is invasive, and you can't mechanically ventilate somebody who doesn't have an artificial airway. We can't just put a mask on and ventilate them. So this is going to exert positive pressure on the airways, push air into the lungs, causing those alveoli to participate in gas exchange. Hopefully, that is the job of the alveoli, gas exchange. And that is the whole purpose of mechanical ventilation. So the exhalation part is going to occur passively. So that's going to occur on its own, but the pushing of the air, the ventilation, the inhalation is going to be controlled by a machine. So this can be delivered by pressure cycled or volume cycled. Now this is some more information than you need to know, but this is all going to be related to the condition. of the patient. And whenever you have somebody on a ventilator, it has to be managed by a pulmonologist. So if you are in the ICU and there's an ICU doctor called an intensivist, they may set up the beginning settings, but there has to be a pulmonologist on the case because they will take over that. Okay, so pressure cycle ventilators deliver air into the lungs until the preset air pressure is reached. Okay, it's all about pressure. Volume cycle ventilators deliver air into the lungs until a preset volume is reached. Okay, so different settings. We're not going to get too much into settings right this moment. But I do want you to remember what a PEEP is. And we're going to see the definition on the next page, but a PEEP. So if you remember in class, I described this pressure when we breathe. When you exhale, if you tried to exhale all of the air in your lungs, like you breathed out until you could not breathe out anymore, there's still air in your lungs that never leaves. And it's just a little puff of air in there that keeps your alveoli open at all times. So if you didn't have that air, it would be really hard for your lungs to take a breath of air naturally. It would be more, the effort would be more effort for you to breathe that way. Just like if you were blowing into a balloon that was brand new, to get that first burst of air into the balloon is much more difficult than if you already had a little puff of air in there, but it would blow up much easier. So it's the exact same concept. So a PEEP on a ventilator is that same simulation. So if you have a really sick patient who has issues with alveoli collapsing, like in ARDS, okay, acute respiratory distress syndrome, which is what part of the problem, then they require a PEEP. And not just any PEEP, but a higher PEEP than maybe some other people would need on the ventilator. So if you have an issue with collapsing alveoli, like in ARDS, then you're going to need a higher PEEP to maintain those alveoli to be inflated. And this is going to cause some side effects, so just keep that in mind. So increased levels of PEEP increase the risk of barotrauma, which is popping alveoli. So there has to be a balance. So typical vent settings include FiO2, the rate, tidal volume, flow, and PEEP. So these are the things that you want to give and report because we don't have to give every single setting. There's just a handful of settings that you want to, which is relevant, which is priority. So mechanical vent settings. So FiO2, that's the fraction of inspired oxygen. So it's the amount of oxygen in any given gas. So if you look on your ventilator and you see FiO2 30%, because FiO2 is a percent, then that is the amount that you're going to give and report. That's the amount of oxygen the patient is on. If you have a patient who's being ventilated and you're getting report and you say, okay, what's the FiO2? And they say 100%, then your next question should be, what are they saturating at? If they say they're saturating at 88%, you should be worried because there's nowhere to go. Because if you're at already 100% FiO2, you can't give the patient any more oxygen. You've reached the, like you can't give 110%. 100 is the max. And if they're saturating at 88%, like what are you going to do? There's nowhere to go. Patient's going to die. Or I shouldn't say that. They're very sick and you need to watch them closely. Okay, so that's how you should start thinking of things. The rate is, the number of respirations the patient receives per minute. Again, this is programmed into the vent. Tidal volume is the preset amount of air delivered with each breath, because it's kind of like the amount of air in mLs that you breathe in. Tidal volume. The flow, velocity of gas flow, or volume of gas per minute. And then here's our PEEP, our positive end expiratory pressure. So positive pressure applied at the end of expiration to prevent that alveolar collapse. Again, this is really important in conditions where the alveoli collapsing is the main problem, like in ARDS. Then we have modes of ventilation. So this is also something that you want to give and report. So for example, if I heard the patient was on AC or assist control, the vent is doing all the work. So this patient cannot tolerate being off the vent at all, which is also something you want to keep in mind. If you have a patient on SIMV mode, the synchronized intermittent mandatory ventilation, This is a setting used for patients being weaned from the vent. So if the patient doesn't start a breath, then the ventilator will kick in. But if the patient is breathing on their own, the vent isn't going to breathe for them. So it gives them an opportunity to use their lungs, but there is that fail-safe just in case they're not taking that breath, within a certain amount of time, it will deliver that breath for them. So if you had a patient on SIMV mode, oh, okay, so they're doing okay. They're starting to wean, they're doing more of the work. That's how you should think of it. So these are some pictures of some ventilators, different brands. It doesn't matter if you see a certain vent at the clinical site and you get used to it, and then when you start working, you see another vent. Don't worry, the screen may look a little different, but all the settings are the same. Like all you have to do is kind of orient yourself like, okay, there's the mode, there's a tidal volume, they're done. And there are some things that you can feel comfortable changing on the ventilator, but this is typically managed by the respiratory therapist and they don't really want you touching it too much. So we can change the FiO2. That is one thing you can do 100% because that's their oxygen source. So if you have a patient that is having some respiratory distress and they're on the ventilator and their FiO2 is 30%, you can put it up to 50, 60, 70, like you can mess with it. The other settings, usually the respiratory therapist will be called and they will adjust those. Complications. So can become hypotensive. And oftentimes you don't think, why would a patient become hypotensive from the ventilator? Well, because they are receiving unnatural amounts of pressure from the vent because the vent is pushing in air and that's unnatural. And especially when you have patients who need a lot of pressure, that is going to put strain inside your thoracic cavity. And what's inside your thoracic cavity? Your lungs and your heart and the really big vessels that are delivering blood to the heart, and a really big vessel that is supposed to um, take out the blood from the heart. So I'm talking about the superior vena cava, the inferior vena cava, and the aorta. So all of that and the heart is getting all this pressure in this cavity. So it's going to like impede blood flow, which will cause hypotension and decrease cardiac output, especially to the right side of the heart. So in addition, mechanical ventilation, aspiration, we know that. We want to keep the head of the bed elevated. They're also at risk for ventilator-associated pneumonia. So they came to the hospital with something else, and then we are giving them pneumonia when they get on the ventilator. So this is due to aspiration of oral pharyngeal, so in your mouth area, those secretions, or gastric fluids from maybe from vomiting, or maybe they weren't kept at least 30 degrees, they were laid flat, and then gastric fluid was able to kind of leak up, kind of like reflux, and then it goes into the lungs. So this usually develops about 48 hours after intubation. So if you have a patient that was intubated and it's been 50, 55 hours, and this is the time you need to look out for that ventilator-associated pneumonia. Okay, so usually develops after 2 days after intubation. Not extubation, after intubation. Okay, infection, again, our normal defenses are bypassed. It's a foreign object in our body. And then barotrauma, because of that increased pressure from the ventilator, it can cause those alveoli to pop and rupture. It can also cause a tension pneumothorax where air gets trapped inside that lining. Again, a result of all of that high pressure. This is going to result in the need of a chest tube. So the ventilator, no matter what brand you have, is going to have a high pressure alarm and a low pressure alarm. So I remember when I first started off as a new grad and they gave us an in-service on ventilator alarms, there was a rule. You never pass by a room when there is a high pressure alarm going off. Technically a low pressure alarm either, we want to check our patient. But if it's not your patient and you walk by and a high pressure alarm sounds, you need to, look at that patient. So common causes of this alarm can be an obstruction. So like a mucus plug or a lot of secretion buildup is going to cause that high pressure alarm. So obstruction is bad because that's the tube that oxygen flows in. So we don't want obstruction. We want to keep our airway patent, our ABCs. So we want to suction that. The patient can be biting the ET tube. Again, it's causing a obstruction in that airflow, the alarm is going to go on. Pneumothorax. So we talked a little bit about that. If you have asymmetrical, oh no, we haven't talked about that yet. Okay. Asymmetrical chest rise and fall. We're going to talk about it in a second. Decreased breath sounds over that site. We want to make sure that we can identify those signs and symptoms and let the doctor know. Patient could be anxious and fighting the ventilator. So they're actually breathing against the ventilator, causing pressure in the tube, so that can put the alarm on. Kink in the tubing, that's an obstruction. Water collected in the ventilator tubing, very, very common. There's condensation. They're receiving sometimes humidified oxygen, so that tube, if there's a loop, it's just gonna like build up in that loop and it will sound once it gets to a certain amount. So we want to keep that empty. And again, that's a really easy fix. Usually just kind of raise the tube and then the water goes down to like this little collection device. Now, if that little collection device gets really full of water, then you want to call your RT because they will manage that. And then low pressure alarm could be a little leak, meaning that they're still getting the air, but we need to check for leaks. Leak in the ventilator circuit and the cuff link, that can be actually in their actual trach because that can happen. It's not common, but that can happen. They may need to swap the trach out. And then if the patient stops breathing and they're in an SIMV mode, which is like one of the lower lows or a pressure support mode, then you need to tell the doctor because maybe they need to adjust those settings on the vent. Okay, so nursing management for a vented patient. So 30 to 45 degrees, anything lower than that is not okay. Not okay, less than 30 to 45 degrees. We have to maintain that airway. So we want to suction the patient. We can do CPT, which is when we pat the chest to loosen secretion so they're more easier to expel. Frequent position changes because if they can't get out of bed and walk, we kind of have to facilitate that. And that also helps to drain. If they have a lung problem, it can help drain, certain parts of the lung by repositioning so we can suction it out. Daily readiness to wean. We want to make sure every shift, every day we're checking to see if we can change the settings to get them off that vent. Sedation, vacation. Peptic ulcer disease, we talked about that. DVT, we talked about that. Daily oral care, really important with chlorhexidine. So we talked about if a patient is on a ventilator and they are having some distress, they are fighting the machine, they're turning red, their heart rate's going up, the vent is alarming, something is wrong. If you try to adjust the settings, say you put the FiO2 higher and they're still struggling, then we need to take them off the vent, disconnect from the vent, and we need to bag them with an ambu bag, which is called a bag valve mask. That is the technical term, so remember that. And you want to make sure that that ambu bag is hooked up to oxygen. You don't want to ventilate with room air. You want to make sure that is up all the way open on the wall and ventilate them with an ambu bag. Weaning criteria. Important that you know what the weaning criteria is. So we're not going to wean a patient who is too unstable to wean. We want to make sure they're able to breathe spontaneously. And these things are kind of common sense. We want them to be able to breathe on their own. Ability to support adequate oxygenation. So if we are doing breathing trials and we take them off and they start to desaturate, then they are not ready. Ability to maintain hemodynamic stability. So we're going to look at their blood, their circulation, their blood pressure. So we want to monitor to make sure they have stable vital signs, stable ABGs, minimal secretions, adequate oxygenation, spontaneous breathing, and is free of sedation medications. They need to be alert because even you and me, if we're really sedated, we can lose our airway. Okay, we can't really breathe on our own. So for these patients, it's important that they're off sedation so that they could breathe on their own. So criteria for weaning. This is individualized for each patient because each condition has a different problem. So we want to make sure that they are stable. That is the goal. So pH greater than 7.25. Wow, that's really low, right? That they can still be in acidosis, but technically this is the criteria. So 7.25 or higher. They have to have a PEEP less or equal to 5 to 8. So remember, PEEP is that pressure that's going to keep the alveoli open. And if you have a really, really high PEEP and then you take it away, they're at risk for having atelectasis, where those just cave in on themselves. So we don't want to risk that. So if they're not able to tolerate a PEEP less than 8, then they do not meet the criteria for weaning. FiO2 greater than 150 to 200. So this is a ratio, and you don't have to know the ratio, so don't worry about that. Hemodynamic stability. So no active ischemia from an MI, no hypotension. Um, so for example, if the patient requires like really high doses of vasopressors to maintain their blood pressure, then they may not be a candidate for weaning at that time. But if they have a small dose, it will be considered again on an individualized for the patient. And inability to initiate an acceptable inspiratory effort. Again, if they're having a hard time breathing, then they're not going to do well on the weaning trials. If the patient is able to tolerate a spontaneous breathing trial for 30 to 2 hours, again, this is facility specific, without tachycardia, hypertension, hypotension, deteriorating ABG results, or arrhythmias, then they can extubate. Okay, so remember, if you have those telltale signs of respiratory distress like tachycardia, it could be hypertension or hypotension, ABGs are not looking good, then we're not going to continue to wean. So what will usually happen is we'll know their baseline ABG on the vent. We start the weaning trial, and then once they're real deep into the weaning trial, we'll draw another ABG to actually see how they're doing. Because sometimes a patient looks fine, and you're like, oh yeah, they can be extubated. But then when you look on their ABGs, maybe their CO2 level is really high, and you're like, no, 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 they're retaining carbon dioxide. You just don't see those effects yet. So they wouldn't be able to wean just yet. After extubation, the patient is placed on oxygen always. And this is just support, just to make sure that we don't lose them. It can be a face mask, it can be a nasal cannula. It just depends on the patient until they're assessed to make sure they're breathing adequately. So here are some more weaning methods. So pressure support, they can be placed on a CPAP, on a T-piece. So what can happen if maybe they were deemed appropriate to start weaning and so they extubated them? Well, they can end up being reintubated. That's not uncommon. Sometimes it just happens. They can aspirate secretions when the tube is removed. They can develop stridor, which is caused by injury to the larynx or the glottis, causing spasming. So they will need to be reintubated, or sometimes they even need an emergency trach. So we don't want that to happen. That's why we want to make sure that they're ready to be weaned. Okay, so let's talk about chest tubes. This one is an important one. So chest tubes allow for the removal of air and or fluid while allowing the lung to re-expand. So our air should only be in our lungs. Our lungs are like two balloons. So outside of that balloon, there's a membrane. So in between the balloon and the membrane, that's what we're talking about. Things can get trapped in there. And when things get trapped in there, it starts to push our lung closed. And if our lung can't fully expand, we're going to have problems. And sometimes it gets so full of air or fluid, it's going to push against the trachea and the heart and the other side of the other lung. That is a tension pneumothorax. So we really don't want that to happen. Okay, so back to the chest tube. So the chest tube that comes out of the patient is going to, right here, connect to a collection device. And this is a special collection device because it needs to allow things to escape, either the fluid or the air, without letting anything go back in. So essential components we're going to talk about is the collection chamber, the water seal, and the suction. So one side is hooked up to the patient, and then the other side is hooked up to suction on the wall, okay, on the wall. So here is a description. So you have a generic drawing here, and this atrium that you see on the right, that is what you're going to see in practice. This is the most common one. In the places that I've worked, this is the only one I've seen. I'm pretty sure there's other types, but this one definitely you'll see. So you can see the chest drainage unit. This side is connected to the actual patient. This is where the blood or the air is going to collect from that pleural space. So it's going to fill up these chambers and this chamber, and there are measurements. So on your shift, you're going to mark with a Sharpie your level. Okay, so the time, date, and initials. So this is something you want to check and report. So if the nurse is saying, yeah, patient has a chest tube, I had 200 mLs of fluid out, okay, maybe serosanguine is fluid, you want to go to the chamber with the nurse and just make sure that they documented their line here, because sometimes you go and they said, oh, I had 200 mLs out, and then when you go it still has like the line from the previous night shift or day shift or whatever. So you want to, that's something that you should do with your nurse just to make sure you guys are on the same page, because you don't want to mark them at, oh, she said 200 mL, so I'm just going to mark it for her. No, 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 that's not right. Make sure you have your other nurse check it with you. So when you set this up, you are going to put in sterile solution, normal saline or sterile water, whatever the kit tells you to do, and you're going to fill it up to pre-marks. You're not guessing anything. You put it to 20 centimeters. You have a water seal chamber here. Now what you need to know is what this means, what the bubbling means to you. Okay, so one thing, when you hook this up to suction, we can control the amount of suction, right? There's like a little valve. So you don't, once you put the suction on, it's going to start to bubble in the suction control chamber. And you don't want hard bubbles. You don't want it to be like you're boiling pasta, like that rolling bubble. You just want a little bubble. That little bubble just means that the suction is on. That's all this means. The water seal chamber is where we're going to like troubleshoot suctioning, whether it should be bubbling, continuous, tidling, whatever. But this suction control chamber, that's always going to be bubbling, because you're going to, that's where the suction goes. If you have your bubbling too much there, you're going to lose a lot of water through evaporation really quickly, and then you'll have to refill up to this 20 centimeter line more often. And it's not necessary to have a rolling bubble here. Okay, so a little bit about chest tube placement. So pneumothorax, that is when air is in that pleural space. Air rises, so your chest tube will be placed higher up here in the lung. For hemothorax, which is blood is fluid, it's going to sit at the bottom. So this is where you're going to have a lower chest tube placed. So when you are assessing your chest tube drainage system, you want to measure and mark, like I said, and document that. You want to assess what color and consistency. So if you have a lot of red free-flowing drainage, more than 70 mLs an hour, that could indicate possible hemorrhage. If it's cloudy fluid, like it's not clear, that can be infection. And if you have a sudden increase or decrease, then you want to make sure you tell the doctor, because usually abrupt changes, that is not normal. Okay, water seal chamber. So you're not talking about the suction chamber that from before. We're talking about the water seal chamber. That's the second chamber. So initially, there's going to be a lot of bubbling on expiration when they exhale. And that shows that there's still air coming out from the pleural space. So at the beginning, bubbling, we expect it on expiration. Later, there's not going to be as much bubbling, because a lot of the air has already left, and instead the water will tidal. It'll kind of tidal and fluctuate with breathing. So it'll just kind of go up and down, kind of like water on a shore of a beach, kind of back and forth. And that's going to happen later once most of that air has left the cavity, which is what we want. Once whatever is going on in there heals, then that water fluctuation may not even happen anymore. And that's when we know, okay, the patient is probably ready to have the chest tube removed. If you have continuous bubbling in that water seal chamber, it's likely going to be an air leak somewhere, and you need to check the lines to make sure that they're intact. Subcutaneous emphysema. And this is not normal. This is air trapping in the skin, and when you see it, it looks kind of puffy, like it's like the skin is kind of bulging. And if you feel it, you're going to feel crepitus, which is like that crackling feeling. This is not normal. It's not painful for the patient, but if you get a lot of crepitus, especially in these strange places, like sometimes you can get it like under your eyes, on your eyelids, that is can be uncomfortable. So this means that there's air escaping into that space. So this can happen when you have like a rib fracture and it pierced through the skin, and you still have like you could have a chest tube in there, but maybe you have some air leaking out somewhere else. It can also mean that the chest tube is not positioned properly or has moved inside. If you have this subcutaneous emphysema on the head or neck, it can be life-threatening because that could mean your airway is compromised. It could be like a leak in your trachea. So leaks are bad if it's in our airway, so that can be an indication, it's not normal. That's what you need to remember. That is not something that we expect to find. So chest tube management, we want to maintain a closed system. So just like a Foley catheter, like we don't want to break the line. We want to like tape all the connections because the connections are just by pressure and there's no like clicking that happens, things, it's literally just two tubes in like one tube in the other one. So we tape the connections. We want to make sure that the container stays below the level of the chest and that there's no kinks or loops in the tube. We never want to clamp the chest tube. We always have hemostats, clamps at the bedside. These are like really big ones just in case, but we don't ever clamp it because if you clamp it, especially at the beginning when the patient still has a lot of air trapped in there, remember they're breathing and they're breathing in air with every inhalation. So that air is going to become trapped and it can cause worsening pneumothorax or worsening hemothorax, and it can lead to tension pneumothorax, which is a medical emergency. So we do want to give patients pain before walking if they're able to ambulate, and pulmonary toileting. So pulmonary toileting is like using the incentive spirometer. It's coughing and deep breathing. Just because they have a chest tube does not mean they shouldn't be doing those things. All of those things help the patient to recover faster. We want to keep a sterile occlusive dressing at the bedside just in case there's accidental dislodgement. In the picture, you can see Zeroform. It's like a mesh that has like petroleum jelly on it, so air doesn't pass through. When the chest tube is removed on purpose, like okay, it's time to take it out, we want to apply that sterile petroleum dressing just to seal the hole so no air is coming in or out for at least 1 day to 2 days. After that, the pain should start going away just like any other healing, like a wound stoma. It should decrease over time. Pain should decrease over time. Patients should report signs and symptoms of infection or inflammation. So there should not be any purulent discharge. That is abnormal. That is a sign that they need to call their doctor and come back to the hospital. Also, when the chest tube is still in place, we should not strip clots from the tube. So we don't, squeeze stuff out, and we don't milk. That's the same thing. Stripping and milking is the same. So we don't do that. Okay, we're moving on to our disorders next. First condition, pulmonary embolism. I think we're all familiar with how you get this. So we're just going to go into a little bit more depth. So by definition, the obstruction of one or more of the branches of the pulmonary artery by particulate matter that has an origin somewhere else in the body. So technically, it doesn't have to be a DVT. It can be just some other thrombus floating around and it gets into your lungs. But DVT is going to be the number one risk factor. So thrombus is the most common cause. Other causes could be a piece of a tumor, even amniotic fluid during pregnancy, air, or fat. So an example of air embolism would be during an insertion of a central line, air can get into the vessel. If there's enough of it, it can cause this PE. Or fat, if you break a big bone, like a big long bone, because we have red bone marrow and yellow bone marrow. That yellow bone marrow has fat cells in it. So if you have like a big break, a fracture, and that fat gets dislodged and it goes into your bloodstream, it can cause an embolism. So some different reasons, but we're going to focus on the DVT. So epidemiology, 1 to 2 cases per 1,000 persons in the US. That's pretty common. For every 1,000 people, 1 to 2 people are going to have a PE. Causes a lot of deaths, and it's the third most common cause of death in hospitalized patients, which is a lot if you think about it. Pathophys, blood clot lodge in pulmonary artery. It results in a ventilation perfusion or VQ mismatch, which we're going to talk about next. Okay, so VQ mismatch. So just by the words alone, what does it mean? So ventilation means breathing in and out. Perfusion, we're talking about the ability of the red blood cells, so like blood, to participate in that gas exchange because we need blood and oxygen. We need our blood to drop off carbon dioxide and pick up the oxygen from our lungs, and we need to ventilate to bring the oxygen into our lungs. So this is a mismatch. There is a problem here. So we have two types, low ventilation and high ventilation perfusion mismatch. So let's start with the low ventilation. So we have, let's see, adequate perfusion through poorly functioning alveoli. So poor ventilation with adequate perfusion. So poor ventilation. So our breathing is not adequate. So the oxygen isn't coming in, the oxygen isn't making it where it's supposed to be, but we have adequate perfusion. So we have the red blood cells waiting for it, but something's going on with the alveoli, it's not working. So with ventilation perfusion mismatch, there is no perfusion of functioning alveoli by the pulmonary capillaries. So there's no blood coming in to pick up the blood to pick up the oxygen that the lungs are bringing in because of the obstruction from from the embolism that's lodged there. Okay, so it just means ventilation perfusion mismatch. We have the oxygen coming in from a PE because we're breathing in oxygenated air, but there is an obstruction of blood flow, so there's no blood in the capillaries like waiting for, the oxygen to come in. So PE, pulmonary embolism, results in decreased oxygenation, decreased cardiac output, and hypotension. Those are our problems with the PE. Decreased oxygenation, decreased cardiac output because there's a block, right, of the blood, and hypotension because the blood is being blocked. So pulmonary embolism, stable versus unstable. So you could have a pulmonary embolism, but still have normal blood pressure, no right ventricular dysfunction, and no elevated biomarkers. So your troponin is normal, your BNP is normal. That is low risk. You can be given medication and you can probably be treated as an outpatient. But we get up a little more severe, intermediate risk, high risk. So you can read through this. Intermediate, you got normal blood pressure, but your heart has been affected and you're starting to have those elevated labs. And then with the high risk, everything is abnormal. You have hypotension, you need medication to maintain your blood pressure. Your right and left side of your right and left heart are having issues, and you're actually going into shock and or cardiac arrest. So that, of course, that's high risk. Okay, so here's a picture so you can see that there's an embolus, it breaks off. They're giving you an example of like a DVT, travels to the lungs, and you start occluding blood flow. Not only blood flow, but oxygenation because the lungs provide that location, but there's a mismatch. So risk factors. Presence of DVT is number one. Again, we're going to focus on that, but obesity, smoking, heart disease, fracture. Again, we're not only talking about a blood clot, we're talking about like an air embolism, fat embolism, major surgery, and so on. So the greatest risk for PE is going to be this DVT, so we should know how to prevent it. So Virchow's triad, venous stasis, vessel wall damage, and hypercoagulability, those three things can lead to DVT. The most common cause, though, is prolonged immobility. So you can see here, you can read through this table from your textbook. And again, those same risk factors for DVT, don't forget them. Back to pulmonary embolism. So the three hallmark signs are going to be dyspnea, which is shortness of breath, pleuritic chest pain, which is that stabbing pain, usually on one side of your chest, especially on inspiration when you're inhaling, and tachypnea, so increased respiratory rate as your body senses like, hey, something's going on, let's breathe faster to try to compensate. Accessory muscle use, tachycardia, crackles might be present because things are starting to get backed up, cough, and hemoptysis, so bloody sputum. So the definitive diagnosis here, imaging-wise, is going to be that spiral chest CT with IV contrast. Spiral chest CT is our go-to exam. We could also do a VQ scan later. Okay, that's not the primary definitive way to do this because a VQ scan takes longer. It's in nuclear medicine. Pulmonary angiography. So this we give the patient an injection and it lights up the vessels. They can also be diagnosed that way, but that is not the go-to. It takes longer and not all facilities can do these pulmonary angiographs. ECG to rule out MI because there can be similar signs and symptoms. Chest x-ray to rule out other stuff. Bilateral Doppler to see if a DVT was actually the culprit because that will determine patient education later and we can try to prevent another PE from a DVT in the future. Labs, we're going to do D-dimer. So the D-dimer measures some of the products that are broken down from the clot as the body tries to dissolve it. It releases like these proteins, so the D-dimer measures that. So a D-dimer is not a way to diagnose a PE, it's just used in combination of. So if you had a patient that came in with shortness of breath and these 3 hallmark signs, and maybe they just had a recent surgery, you're going to think pulmonary embolism right away. Maybe while they're waiting for their chest CT to be done, you draw labs and D-dimer will be a part of it. So if their D-dimer is elevated, the doctor will likely say, yeah, you probably have a PE, but it's confirmed with that spiral chest CT. ABGs, hypoxemia because oxygen is directly being affected, right? So your PO2 is going to be less than 80 because remember an arterial blood sample, when we check oxygenation from an arterial blood sample, 80 is going to be normal for us. We think of our SpO2 or pulse ox as being higher than 90, but remember for a PaO2, an arterial blood sample, 80 is normal. So less than 80, we think hypoxia. And then respiratory alkalosis, because if you remember the 3 hallmark signs and symptoms of PE are tachypnea is one of them. You're breathing faster. So you can think of hyperventilating, so you're breathing fast because your body is starving for oxygen. It's going to lead to respiratory alkalosis because you're breathing off carbon dioxide. But eventually, it's going to switch over to respiratory acidosis as the condition worsens because you're going to have increased respiratory effort. You're going to have a harder time breathing, period. So it's going to turn into respiratory acidosis later. Late sign, early sign, respiratory alkalosis. Also, patients could have an increased BNP, not always, but this is an indication that the ventricles are really, really stretching. That can be an indication of heart failure. So treating pulmonary embolism is going to be based on the severity and the risk factors the patient has. So if it's a mild case, then, like I said, they can be treated at home. But if it's severe, then they're going to need more aggressive treatment. Supportive care. So supportive care includes whatever the signs and symptoms the patient is coming out with, like oxygen would be a type of supportive care. Fluids are supportive care. Medication-wise, anticoagulants. So anticoagulants don't reduce the size, it prevents it from getting bigger or for another clot to form. So if the patient is asymptomatic, then they can be treated at home. If they're symptomatic, again, that's going to bump the patient up on our priority list. They become unstable when they're symptomatic. They need to be hospitalized. They're going to receive heparin therapy. So how do we do heparin therapy? So dosages are weight-based, so we need to make sure we get a weight, and we are going to monitor this through blood by way of APTTT, or just PTT for short. That's going to be activated partial thromboplastin time. And usually we're going to get a baseline PTT, and then we're going to get a PTT every 6 hours after that until we reach therapeutic goal at least twice. So the therapeutic goal is going to be 1.5 to 2.5 times normal the value, or 40 to 90 seconds. And pharmacy will manage this, but you should be aware. If you have the blood drawn and twice in a row it's within therapeutic goal, then your lab draws will become less frequent. Instead of every 6 hours, it will change to like every 12 hours and then every 24 hours once the patient becomes therapeutic. Things to look out for. Actually, before we do that, the procedure. So when you get a heparin therapy ordered for PE, or in general, usually the patient will get a bolus first of heparin. So this little vial, it's the same type of vial that you would draw from to give like a subcutaneous injection. You, per doctor's order, it could be 5,000 units or maybe sometimes 2,500 units, just half the vial. But you inject it as an IV push. Okay, so it's an IV push. You flush the line just like anything else, and then you start your heparin infusion. So this is a high alert medication. So you will need to have a second nurse come in and verify your order and your pump settings. And that includes every time you change the rate. So like say you get started with an IV heparin infusion and then it's been 6 hours and your levels come out as not therapeutic and you need to raise the milliliter rate per hour, then you need a nurse to come in with you to witness it and then sign off in the chart. Okay, so back to this. Caution with heparin-induced thrombocytopenia. So this is an autoimmune reaction. It is life-threatening, and it happens when heparin is introduced because our bodies produce our natural heparin. We have heparin in our bodies. So this is foreign, right? This heparin is not us, and sometimes your body will have an autoimmune response, and during that response, it's going to clump this artificial heparin with platelets in your body. They just start clumping up. So you start to clot inside. So you have heparin, which is an anticoagulant. Your body begins to have an autoimmune response, and it starts to clump up all your platelets. So two things are going to happen. You're going to have all of these clots, which is bad, and you're going to have a decreased amount of platelets because they're busy making clots for no reason. So then you're going to have a tendency to bleed. So you're clotting and bleeding at the same time. That is life-threatening. So what we want to do is first identify the signs and symptoms of HIT. So you're going to have this hypercoagulability, so clotting, and you're going to have a drop in platelets. And actually, the way we know is 50% from their baseline. So you don't need to know that, but you do need to know the normal value of your platelet count, which is 150,000. So if you have less than 150,000, you have thrombocytopenia. And if you know your patient is on heparin, and it doesn't even have to be an infusion, it can be the sub-Q injections too, or it could be Lovenox, because Lovenox, or the generic is enoxaparin, is a low molecular weight heparin. It is also heparin. So technically, if you have a patient on an IV heparin drip or has been receiving heparin subcutaneous for a few days, and you notice that they're bruising easily, they have petechiae, like dots of like red dots on their skin, and their platelet count is low, and it wasn't low when they first came into the hospital, then that is an indicator that they might be developing this autoimmune response called HIT. You're going to call the doctor, of course. So what's likely going to be ordered is argatroban. And this is a type of anticoagulant, but it's not going to be heparin, okay, because this patient still needs an anticoagulant because they're starting to make all these little clots. So that is a medication of choice for HIT. And then we have our reversal agent, which is protamine sulfate, just in case they get too much heparin and they start to bleed out. You know, they start to have blood in their sputum, they have blood in their urine, they start vomiting and it's bloody. They might be too much anticoagulant, so the reversal agent is protamine sulfate. Very highly tested on the NCLEX. So treatment continued. Sometimes when all else fails or they have a really, really large clot, they may need alteplase. And this is very high risk for bleeding. So specialized cases, the physician will determine whether this is going to be an appropriate treatment for them. So patients that are recovering from PE, they're going to need anticoagulation for at least 3 months after discharge. And this is going to be usually in the way of like warfarin. But because warfarin needs to be at a therapeutic range, right? We use INR to monitor that. The goal is going to be 2 to 3. So because we need to work up to that goal, we're not just going to discontinue the heparin. They are going to stay on heparin until their warfarin becomes therapeutic. Okay, so what usually will happen, they're in the hospital on heparin, and then we start the Coumadin or warfarin in the hospital at the same time. And then once heparin or the warfarin becomes therapeutic, so their INR becomes between 2 and 3, then we can stop the heparin. The heparin has a very short half-life, so we stop it within 12 hours, it's out of their system. And this can happen at home too. Sometimes patients are discharged with enoxaparin or heparin, and they're told to take it until, the doctor tells them to stop. And of course, we need to educate them on bleeding, risk for bleeding stuff, right? Sorry. Okay, surgical management. So sometimes if they have a clot and they're unstable and they can't have these thrombolytic agents like alteplase, then they may need to have surgery to go in and actually remove it. So of course we don't want to do that. That is invasive. That has a lot of risks that accompany with that surgery. So but sometimes it's indicated. Or a patient can have an IVC filter put in. So it's literally a filter, like this metal, here it kind of looks like an umbrella, like a little hand, that is placed in the inferior vena cava, which will catch blood clots. So patients who are high risk for developing clots in the future will have an IVC filter put in. This is done by interventional radiology. It's pretty it's invasive because we have to go through an artery to place it, but it's pretty common. And some IVC filters stay in forever, and then they have these like newer ones that can actually be removed. So the one in the picture is one of the newer ones where they can remove it, and you can see it did its job. It caught some clots. All right, so what do you need to do? So I included the nursing diagnoses, which is just the problem list of a PE. So impaired gas exchange, so you're thinking oxygenation, elevating the head of the bed, ineffective breathing pattern. So we know this is going to be related to possible pain and hypoxemia. So we're going to give medications as ordered. We're going to also want to give IV fluids because the patient's going to have decreased cardiac output because of the blockage in the pulmonary artery. Institute bleeding precautions. That's what I meant to say, bleeding precautions. So if we don't have to poke the patient, let's not poke the patient. Apply pressure when we do poke the patient. Safety. And we always want to be prepared for the what ifs just in case things go south. So be prepared for intubation and CPR because this is a big deal having a severe pulmonary embolism. So teaching whatever the problem that caused this, we want to focus on that. So if it's related to a DVT, then we want to get, since we know immobility is one of those high risk factors for DVT, we want to make sure that they exercise, eat healthy, fluid intake, don't smoke, take their medications, bleeding precautions, of course, diet, limit food with vitamin K if they're on warfarin, because that can decrease the effectiveness of warfarin. And then make sure they know the signs and symptoms of a DVT or PE because they might come back. Next is acute respiratory failure. So acute respiratory failure can be related to oxygen or carbon dioxide or both. So either there's something going on with gas exchange and it can lead to type 1 hypoxic respiratory failure or type 2 which is hypercapnic, which is retaining too much carbon dioxide. Respiratory failure can lead to death. So this is part of our critical care illnesses because it can lead to death really quick. Risk factors: pulmonary edema, pneumonia, pulmonary embolism, hypercapnic respiratory failure, asthma, narcotic overdose, and myasthenia gravis because that's related to muscles. The muscles that we need for breathing don't work. So this is not the only risk factors. The risk factor list is very long. So signs and symptoms. If it's related to a lot of carbon dioxide retention, patients will experience headache, confusion, decreased level of consciousness. If it's related to low levels of oxygen in the blood, hypoxemia, changes in respiratory rate, heart rate, and blood pressure. So one way to remember that, hypoxemia, you're going to have those vital sign changes, and a lot of carbon dioxide, you're going to have neuro, so headache, confusion, decreased level of consciousness. And then the clinical manifestations of respiratory failure in general, we have an early and we have a late. So very related to like hypoxemia, if you remember that. Shortness of breath, restlessness, anxiety, fatigue, increased blood pressure from baseline, tachycardia. So your body is very uncomfortable. It is oxygen starved. Your body's going to try to compensate. So intermediate, then we go to the neuro, confusion, lethargy, pink skin discoloration, that's going to be related to increased carbon dioxide. And then late is always going to be that cyanosis. If you see blue anything, that is a late sign. Patients have been starved of oxygen for a while. And then coma, of course, that means our brain has been severely affected by lack of oxygen where it just kind of shuts down. And that is bad, right? That is a worsening condition. So diagnosis. So one thing to note that acute respiratory failure is not a disease. It's caused by something else. So you're not going to have the disease of respiratory failure. This is something because something else happened. So diagnosis. ABGs. Initially, just like PE, you're going to have respiratory alkalosis because your body is compensating, is trying to get air, is trying to breathe faster. But as a result, it breathes off a lot of carbon dioxide. So you're going to have respiratory alkalosis at the beginning. We're going to want to check our venous oxygen saturation, or SVO2. If you remember how we get that, there's two ways. You can get that from a central line, or you can do a VBG, a venous oxygenation, kind of like an ABG, but you're running it with venous blood, so it's like a regular blood draw. But either way, it's going to be decreased. However way you obtain it, it's going to be decreased because the body isn't going to be getting enough oxygen, so it's going to try to pull more oxygen from the blood that it has, right? Hemoglobin and hematocrit. So we want to test that to make sure the patient that it's not like related to anemia, because if you don't have enough red blood cells going around your body, then it doesn't matter how much oxygen we give the patient, there's not enough red blood cells to pick it up. So we want to make sure that their oxygen carrying capacity is where it needs to be. Then we have a chest x-ray. So this is going to show, because remember acute respiratory failure is not the condition itself. A chest x-ray might show maybe a condition that it is causing. So maybe they have pneumonia, or maybe they have like heart failure with an enlarged heart, or a PE. So that's going to rule out or identify another cause. And then sputum cultures. So maybe there is an infectious process going on. So that's what we're going to check for too. So then here, what did I write here? Pulse ox can be used to monitor oxygenation after the ABG is obtained and treatment is started. So when a patient goes into respiratory failure, that pulse ox is not going to be our number one go-to as an accurate measure, because things can affect that. If a patient's in acute respiratory failure, maybe their circulation isn't that great. They're going to start to have like cold extremities. So we're not going to depend on that in acute respiratory failure. We want to get an ABG because that is going to tell us much more accurate information. But once we get the ABG and we know what their baseline O2 is, then that's what we're going to go by. Then we can use the SpO2 and try to keep above 94% or whatever the doctor's order says. Medications, we're going to give stuff for our airway, so bronchodilators and steroids, for inflammation. We'll always give bronchodilators and steroids together because together they are happy, they work much better together. Diuretics can be used to decrease pulmonary congestion, and sedation, because when you are lacking oxygen, you get restless, you get agitated. So we can give some medications just to kind of calm you down and help you breathe faster. We're not sedating them so that they're sleeping, unless of course they're on a ventilator, but just giving them a little medication can actually will help the breathing, ventilating. And antibiotics if they have an infection like a pneumonia. So treatment, we want to treat that cause. We're going to give oxygen. They may need some support, ventilation support, so CPAP or BiPAP, and they may need to be intubated. So they may need an ET tube or even a tracheostomy, just depends. And then mechanical ventilation with PEEP. And with acute respiratory failure, we're just going to say PEEP. We're not saying really high or standard. Remember, 5 is standard. I don't know if I mentioned that before, but 5 is standard. Is like the starting point. Complications, our heart and our lungs work together. If your lungs aren't doing well, it's going to directly affect your heart, and that can lead to cardiac failure or heart failure. Multiple organ dysfunction, because we're not getting oxygen, is going to end with hypoperfusion, organ hypoperfusion, and that's when you're going to see the neuro changes. You're going to see the decreased output because the kidneys are going to start to shut down, and death, of course. So eventual death. So remember your oxygen delivery devices. So our non-rebreather, that is what you give before a BiPAP. So that is going to deliver high concentrations of oxygen. So if you have a patient that has that you're suspecting one side of the lung is not working, like maybe they're having a really bad asthma attack and you auscultate the lungs and you can't hear any breath sounds on one side, that's really bad. Apply the mask. Apply the non-rebreather mask. Okay, remember that example. And then we have pictured here a vent or a BiPAP, which we talked about. Okay, so this is a general slide on how we're going to assess these patients with acute respiratory failure. So assessment-wise, we're always going to go with ABCs because we're talking about our lungs. So you are going to make sure you assess for airway patency, especially if the patient is intubated or has a trach. Vital signs, you're going to look out for those early signs and symptoms of our body compensating. So the heart rate, blood pressure, respiratory rate. We talked about ABGs at the beginning. The patient will be in respiratory alkalosis, and as it progresses to become more severe, the patient will be in respiratory acidosis. Cardiac monitoring, because the lungs and heart are friends, and the heart can start having dysrhythmias when it becomes deprived of oxygen. We're going to listen to the breath sounds, and we're going to make sure we're also looking at the skin color because we're thinking cyanosis, but we're also thinking too much carbon dioxide that can kind of give that flushed red appearance. Interventions, we want humidified oxygen. If we are bypassing our body's natural defenses with an ET tube, it's not getting naturally humidified, so we want to make sure we humidify it. We're going to give those bronchodilators and steroids, diuretics, and sedation if needed. Head of the bed should not be flat, at least 30 degrees. If we have one lung that has a problem, then we want to position the patient good lung down so that the other bad lung can inflate better without being squished, on that side. Chest physiotherapy, that CPT, where we kind of hit the chest a little bit to loosen the secretions. Suctioning, give IV fluids, nutritional support because patients who have breathing problems use more calories. Think about that really thin COPD patient with the increased respiratory effort. So we need to make sure that they have good nutrition on board. If they're intubated, they're likely going to have an NG tube placed on tube feeding. And then be prepared if the patient is not intubated that they may end up intubated if they continue to decline with their respiratory failure. Teaching, disease process, medications, pulmonary rehab. Hopefully they survive this. Diet and hydration. Of course, stop smoking because smoking is bad all the way around. The goal is to have them return to their baseline activities of daily living, back to work and social commitments after they've experienced this. So next is acute respiratory distress syndrome, or ARDS, ARDS for short. So the pathophys on this, there are 3 stages, which we'll talk about each: exudative, proliferative, and fibrotic phase. So risk factors for this, and we're going to go into exactly what this is in a second. So anything major that happens in the body: sepsis, severe trauma, massive blood transfusion, pregnancy, even just cigarette smoking, cardiopulmonary bypass. So all kinds of stuff can lead to ARDS. So what is happening from ARDS? So there is some type of systemic inflammation going on, and as you know, when our body has that inflammatory response systemically, there are lots of chemical mediators that are distributed throughout the body, and they all are like chemical messengers pretty much. And this goes terribly wrong because these messengers make their way to our lungs, because all of the blood will eventually go through the heart to our lungs to get oxygenated. But when it gets to the lungs, it gets to our alveolar capillaries and it kind of overwhelms them and it causes them to become permeable. So hyperpermeability, those little capillaries, if you remember, if you can see in this picture, this little alveoli sac here is covered with capillaries. So the capillaries begin to open up and fluid floods into the alveoli. And those alveoli should have air in them at all times so that gas exchange can take place. So all of this fluid goes in and instantly it's going to cause a problem. Gas exchange is not going to occur. So in ARDS, not every single alveoli is going to be affected. So you're going to have some working alveoli, and then you're going to have these fluid-filled alveoli. And this can progress worse where all of the alveoli start to fill up. So keep that in mind. One thing that also happens when these chemical mediators start to cause this increased permeability, these chemical mediators are also going to cause damage to the cells in the alveoli that produce surfactant. So surfactant is a material that helps to maintain tension on the alveoli. So if you don't have surfactant, those alveoli are going to have a hard time inflating and deflating as they should. So there's going to be a surface tension. They're going to end up collapsing. And collapsed alveoli are called atelectasis. Okay, so two problems. That increased permeability is causing the fluid to come in, and then the cells that produce surfactant are damaged. So we're going to have very, very little surfactant, which is going to cause a problem keeping those alveoli inflated. So big problems. So in this table here, I listed the risk factors, but we can have direct or indirect causes of ARDS. So direct injury to to the alveoli membrane can be caused by aspiration, direct chest trauma, pneumonia, pulmonary contusion, smoke inhalation injury, or PE, pulmonary embolism. So all of these can lead to ARDS. Indirect injury can be sepsis or shock, pancreatitis, burns, and so on. So both causes can cause, all of these causes can lead to ARDS. So ARDS is defined by three different characteristics, and these are the hallmarks, so you should remember this. Acute onset of less than 7 days. So this is abrupt. You get ARDS abruptly. It doesn't happen over months, weeks, or days. Weeks. This is 7 days or less. Refractory hypoxemia. So the word refractory means that despite our best efforts and interventions, it doesn't help. So these patients remain hypoxic even though we're giving them a bunch of oxygenated air, right? Even if they're on the vent, it's not helping. They are still hypoxic. Bilateral infiltrates will be seen on an x-ray. So when you see bilateral or the word infiltrates on an x-ray, it means alveoli are filled with fluid. So those are the three hallmark signs. So how do you know if a patient is getting better? Well, they're not going to be hypoxic and they're not going to have infiltrates on an x-ray, on a chest x-ray. So remember that. Moving on. Okay, so the three stages of ARDS. Exudative. So this is going to happen within 1 to 2 days after that injury. This is when those inflammatory mediators are going to start circulating and they're going to make their way to the alveoli, and there's going to be disruption of the ACM. The ACM is the alveolar capillary membrane. It's going to become dilated, it's going to open up, it's going to be very permeable. Fluid is going to enter the alveoli, and so is protein. And this protein, is going to attract fluid too, making it worse. This is also going to cause damage to those alveoli cells, so we're going to have less surfactant. You're going to see hyperventilation, so breathing faster, tachycardia as the body tries to compensate. It's going to lead to respiratory alkalosis. Proliferative stage. So this is where the body's like, hey, what's going on here? It's going to send our white blood cells there, which is going to cause more damage. And proliferative meaning things are going to start to grow. So the body is going to try to pretty much damage control. It's going to try to fix the injury. So what's going to happen when these cells try to fix the injury, fibrotic changes are going to occur. So the new tissue is not going to be nice lung tissue. It's going to be stiff tissue, and the lungs are going to become stiff and non-compliant. So compliance refers to the lung's ability to stretch. So the lungs are going to become non-compliant, which means they're not going to inflate, they're not going to stretch as they should, making the ARDS worse. Signs and symptoms of this is going to be hypercarbia, so they're going to start retaining carbon dioxide, and their hypoxemia is going to become worse. So CO2 is going to rise despite the body breathing faster. It's just not going to work. Supplemental oxygen that we give is not going to it's not going to be effective. It's not going to raise the oxygen saturation. So they're going to enter this refractory hypoxemia stage. Increased work of breathing, and they may need the ventilator. If they're already on the vent, they're going to need more pressure to deliver that ventilatory volume because the lungs are going to have a hard time expanding. Then the third stage is the fibrotic stage. So this is a very, very poor prognosis if the patient gets to this stage. So this is where there's diffuse fibrosis. So a lot of lung tissue is now scarred, damaged, impaired gas exchange, pulmonary hypertension worsens because of all of that pressure with the inability of those alveoli to have proper gas exchange, and the patient is going to develop heart failure, and that's going to get right-sided heart failure, and that's going to get worse. Signs and symptoms if they've reached this third stage is decreased left heart preload. So these patients are going to have invasive hemodynamic monitoring, decreased blood pressure, decreased cardiac output, which is never a good thing because that means our organs are not getting perfused, severe VQ mismatch, severe tissue hypoxia, and lactic acidosis because the body is starved for oxygen, so it's going to start using other sources, which is going to create a lot of lactic acid. Patients don't always progress through all stages. They may stay in stage 1, stage 2, and never progress to stage 3. But those that progress to stage 3 will have lifelong consequences, lifelong issues with breathing, air, and or they may not even survive. So diagnosing this, we are going to do a chest x-ray, and you're going to see bilateral infiltrates. Ground glass appearance or snow screen effect or white out effect is where, like you see on the chest x-ray, and it's like all whited out. That's like indicative of ARDS. Labs, ABG, of course, at the beginning, respiratory alkalosis, later respiratory acidosis with hypoxemia, so that PaO2 levels will be less than 80. The more severe, the more decreased PaO2. And PaO2 again is an arterial blood sample measuring the oxygen level. Sputum, blood, and urine cultures, coags, electrolytes, and liver function tests. Again, that's just to see how the body is doing in this hypoxic state. Treatment, they're going to probably need to be on the ventilator. This is the primary treatment for refractory hypoxemia. Lung protective ventilation, that means reduced tidal volumes and higher PEEP. So we have to be careful with that higher PEEP, remember, because that's going to cause the patient to become hypotensive. So we have to have a balance. High flow nasal cannula can be effective for some patients. ECMO, which is where they oxygenate the blood outside of the body and then send it back in, that is a temporary fix. Not all hospitals use that, so that is like a last-ditch effort. Prone positioning, you heard a lot about this with COVID. It helps to expand the lungs via gravity. You can see in the picture when you're face down, the lungs don't have to work against the heart, because when you're on the back, the heart's kind of pushing part of the lungs down, but when you're flipped prone position, the lungs can expand better. But remember that not all patients can tolerate being in the prone position, especially patients who have had a chest injury like a rib fracture. So rib fracture, though, that is contraindicated with prone positioning. Medications, antibiotics if an infection is the source, neuromuscular blocking agents / paralytics. So if they're on mechanical ventilation, we're going to have to sedate them and paralyze them a little bit for this to give their lungs a chance to recover. Hydration, not only does that help to maintain secretions, but they're probably going to have some blood pressure problems, so this helps with blood pressure support. But you want to be careful because our kidneys will most likely be affected if they're in the severe stages of ARDS because they have been hypoperfused, which means they're not going to work that well, which means we're going to see that with their urine output, so we're going to monitor urine output. And nutrition, again, anytime patients having a hard time breathing, they use a lot of calories, they're going to need that energy, those calories. So that might be way of an enteral tube feeding, or they may need temporary TPN intravenously. Complications, barotrauma, alveolar, or lung rupture. So when they have those high pressure, those PEEPs on the ventilator, that can cause alveoli to just kind of explode. Renal failure related to hypotension, hypo-organ perfusion, and medications, especially like antibiotics, are nephrotoxic. Sometimes that can lead to the renal failure. Multi-system organ dysfunction related to just those low levels of oxygen for a long time. Ventilator associated pneumonia or VAP, we talked about that already. Assessments, we are going to have hemodynamic monitoring, both non-invasive and invasive. We want to make sure we check and keep an eye on the heart rate and respiration because we expect those compensatory mechanisms. We're going to check the O2 and the CVP, the central venous pressure. So these patients will have invasive hemodynamic monitoring lines like a pulmonary artery catheter and probably an arterial line that can give us in real time blood pressure readings. And you can read through this. It's everything that we've talked about as far as your responsibility in assessing the patient. Moving on to chest trauma. Chest trauma is likely to happen, or most commonly happens after a car accident. Pathophys can be blunt or penetrating. Blunt does not break the skin, penetrating breaks the skin. Flail chest. So when 3 or more adjacent ribs have been fractured in 2 or more places, could be from a blunt or crushed trauma, and it results in free segment of the ribs. So our lungs function optimally with an intact rib cage. So if your rib cage is not intact, then you're going to have that negative pressure affected. We need that support in order for our lungs to expand and deflate how it should. So when you have pieces of ribs that have been compromised, then you are going to see paradoxical chest wall movement. So instead of it going symmetrical out and in, you're going to have these areas where the lung is not expanding. So you're going to see like weird, strange movement. That is paradoxical chest wall movement. That is indicative of flail chest. So flail chest, paradoxical chest wall movement on inhalation, the damaged area moves inward. On exhalation, the damaged area moves outward. So that brings us to pneumothorax. So this, by definition, is a collection of air in the pleural space, resulting in a reduction in the negative thoracic pressure. Again, our lungs function on negative air pressure. So I gave the example of putting a piece of meat in plastic and then sucking out the air, almost all the air. That helps our lungs to expand and deflate as it should. Well, when you don't have that negative air pressure because there's a leak in that pleural space, it's going to be difficult to inhale. The lungs cannot fully expand. You're going to have decreased gas exchange, and it's going to lead to hypoxemia. And we know what happens when we don't have enough air circulating in our blood. So in this picture, you can see we have the pleural space here because it's a thin little membrane. If air gets trapped in there from something like a fractured rib where it makes the air we inhale get trapped in there, then eventually it's going to fill up with air and it's going to push the lung. The lung is going to collapse and it can lead to a tension pneumothorax. This can happen from a blunt or penetrating chest trauma, and you can kind of read through this. Let's look at hemothorax. So hemothorax is the same as pneumothorax except that it's blood accumulating there, and it can lead to the same thing of tension pneumothorax. So generally, chest trauma is going to result in or lead to decreased oxygenation and ventilation and impaired gas exchange, which makes sense. Diagnosing is going to be related chest x-ray and something called FAST, which is a focus assessment ultrasound. It's used in trauma. So if a patient comes in through the emergency room, they're going to do this quick ultrasound of the chest. And then also a chest CT. Labs, ABGs, lactate, H&H, and all of that should make sense to you why that's included in the workup. Treatment is all about ABCs, airway, breathing, and circulation, because our chest has our lungs in it. So patient may need to be intubated. They're likely going to need extra oxygen and circulation. If they lost a lot of blood, they may also need a blood transfusion. Medications, this is painful. They're going to need pain meds and possibly prophylactic antibiotics if it is indeed a penetrating trauma, because we don't want to add an infection on the list of these patient problems. Surgical management, if you have an unstable chest wall, obviously if you have fractured ribs that need to be repaired, then they're going to need to have a surgery. So complications that can happen from this is tension pneumothorax, which is pictured here. That's where the air keeps building up or the blood keeps building up in there and there's no way for it to escape. Then it's going to start pushing the lung and the trachea and the heart to the other side. That is a medical emergency. So if a patient has a tension pneumothorax, they will need a decompression. So that's where they kind of like stab the patient with a needle to expel the air really quickly. And then a chest tube needs to be placed immediately. Cardiac tamponade, that is when excessive air, fluid, or blood collects around the pericardial sac. So all of that pressure goes in on the heart. The heart cannot pump effectively. So we need to go in with a needle and aspirate that out. That is not done by the nurse, that is done by the provider. One thing to note is that cardiac tamponade and tension pneumothorax can cause cardiac arrest, pulseless electrical activity, PEA cardiac arrest, okay, specifically. So what do we do for this? So it's all about oxygenation. You know how to assess for that. Tachypnea, tachycardia, those are compensatory mechanisms. Low oxygenation, low level of or decreased level of consciousness due to lack of oxygen, decreased or absent lung sounds. If you are just getting this patient, you want to put on a non-rebreather mask, absolutely. Asymmetrical chest excursion, like flail chest, that paradoxical movement. Subcutaneous emphysema can be present. Interventions, give oxygen. You're going to prepare for intubation. Make sure that head of the bed up is head up. Elevate the head of the bed to make sure they have that lung expansion. Encourage cough and deep breathing. Encourage ambulation. Chest tube management, we talked about that. Teaching, all of the same stuff we know. They should be using that incentive spirometer. And if they were in a car accident, then we want to make sure that a little reminder that they wear their seatbelt if they weren't. Our goals is to get them back to their baseline, clear lung sounds, ABGs within normal range.